Welcome back. Now, this is again in continuation of what we have just discussed, the first part of fluid optimization plan and fluid management. This is the second part, and here I would like to just show you this slide where we have just finished the first part. That this we were discussing the crystalloids. Crystalloids and colloids are the two important thing available for us to optimize the fluid condition of any patient, and we were discussing 0.9% saline, also known as normal saline. This was the last indication that this is the only safe crystalloid that can be used with blood transfusion or any other blood product administration. And this normal saline should be avoided in cardiac patients and renal patients, right? So let's start with the second crystalloid that is commonly used in the fluid optimization of any patient presenting to us in the triage or in the emergency room. The Ringer's lactate. This Ringer's lactate, it is almost having similar plasma concentration, the plasma chemistry almost similar, the osmolarity almost similar. Normally the osmolarity of our plasma is between 280 milliosmol to 310 milliosmol, and the Ringer lactate osmolarity is around 278. So almost similar. Whereas the osmolarity of normal saline 0.9%, what we have just discussed, it is around 310, right? So both are isotonic, almost both are isotonic, having similar plasma concentration. And this Ringer lactate. This is the fluid of choice in any burn patient or any patient presenting to us with history of acute trauma in hypovolemic condition. Ringer lactate, right? So burn and trauma patient, fluid of choice, Ringer's lactate. And it is used for acute blood loss to maintain the plasma volume. It is also used in patients who are presenting to us with hypovolemia features. Hypovolemia because of third space fluid shifts. Third space fluid shift means any patient presenting to us with, let's say, ascites or massive pleural effusion, and he or she is dehydrated, or massive generalized edema. In all these cases, the Ringer lactate is the choice available to us. If any patient is presenting with electrolyte imbalance, again this Ringer lactate should be used preferably, not the normal saline in this case. And any patient presenting to us with metabolic acidosis with reduced blood volume or plasma volume, again the choice is Ringer's lactate. In metabolic alkalosis, normal saline. Okay, and in metabolic acidosis, Ringer's lactate. Okay, now this another terminology sometimes used, lactated Ringer. That is a solution in sterile water. Solution of what? Sodium chloride, potassium chloride, calcium chloride, and sodium lactate in sterile water makes the lactated Ringer. Okay, the contraindication of using this Ringer's lactate is whenever patient is in metabolic alkalosis, right? pH is more than 7.5, or respiratory alkalosis. So whenever pH of the patient is more than 7.5 on ABG, arterial blood gas analysis, we'll discuss this ABG in some other video, don't use ringo lactate. Then any patient suffering from liver disease, and if that patient cannot metabolize lactate, avoid this. Ringo lactate should not be given. Then in case of lactic acidosis, don't give ringo lactate. Avoid it. Any patient presenting with renal failure, avoid this ringo lactate, although it is not a clear-cut contraindication, but relative contraindication, yes. In case of renal failure, it should be avoided. Ringo lactate. So pH more than 7.5, liver disease, renal disease, lactic acidosis, 4 contraindications. Next example of crystalloid that is available to us, frequently used after normal saline and ringo lactate, is 5% dextrose. Very few important points regarding 5% dextrose. This 5% dextrose in water, also known as D5, it's an intravenous sugar solution, and these D5, they are both isotonic as well as hypotonic, and the most common use is hypernatremia, frequently used in hypernatremia management. In the continuation of previous fluid and electrolytes videos available in the fluid and electrolytes section in our learners domain, we'll discuss hypernatremia, hyponatremia, then hyperkalemia and hypokalemia within few weeks or days probably. So till then, just remember this 5% dextrose is used for hypernatremia, more of sodium, okay, and this is because of this is hypotonic also. Dextrose 5%, it dilutes the extracellular fluid hat, and it increases in this initially it is hypotonic, and that's why it dilutes the ECF osmolarity, decreases. When cells absorb dextrose and as a part of plasma, and the remaining water after absorption of dextrose and electrolytes, it becomes an isotonic with plasma tonicity. So initially D5, whenever we are infusing it inside the patient, it is slightly hypotonic, and after absorption and after consumption of dextrose by the body, it will become an isotonic solution. Contraindication of dextrose 5% is whenever we want to resuscitate any patient, don't use 5% dextrose. Whenever we want to replace the fluid volume deficit, this is not the ideal choice. In early post-operative recovery phase, don't use dextrose 5%. In any cardiac and renal patients, avoid dextrose 5%. And in all the cases of suspected increased intracranial pressure, avoid it. So cardiac and renal disease, increased ICP, resuscitation of the patient, fluid volume deficit replacement, and in early post-operative recovery, dextrose 5% or D5 is contraindicated and should not be used. Next option that is available under crystalloid is saline, 0.45%. This is also known as half normal saline, and it's a hypotonic crystalloid. used in the management of hypernatremia, right? And it is frequently used in the management of diabetic ketoacidosis, 0.45% normal saline. This crystalloid is contraindicated in burns patient, in trauma patients, and in liver disease patients. Why? Because it causes depletion of intravascular fluid volume in these group of patients. So depleting the intravascular fluid volume is not a good choice in a trauma patient, in burns patient, and in a patient who is suffering from liver disease, chronic liver disease. So 0.45% normal saline should not be given in these group of patients. This 0.45% normal saline may result in fluid overload also in these type of patients, or it may lead to pulmonary edema, difficulty in breathing, dyspnea, congestion of the chest. All these features will be there if we are giving 0.45% normal saline in burn or trauma or other patients, what we have just discussed. One important thing is the rapid infusion of 0.45% normal saline, it leads to RBC hemolysis. So please don't infuse it rapidly. Okay. After discussing the crystalloid part, few important points regarding colloids. The colloids, as you know, these are large molecules, and examples are blood components, the human albumin 5%, 20%, HES stands for hydroxyethyl starch, then hemaxyl. All these are the examples of colloids. The important property of colloids is they are unable to pass through semi-permeable membrane, and that is the reason they remain inside the blood vessels. If they're just remaining inside the blood vessel, they are very much responsible for generating the oncotic pressure, and that's why they always just take up the water from outside and they increase the plasma volume, and that's why they are known as volume or plasma expanders, as they draw fluid from interstitial fluid inside the plasma. Now these colloids, they require less volume than crystalloids in the ratio of 1:3. Means if we want to increase the oncotic pressure by 1 unit, and if that 1 unit of oncotic pressure is being increased by giving 3 liters of crystalloid, for the same increase we just only need 1 liter of colloid for the same increase in the oncotic pressure. Okay, and this is basically indicated in malnourished patients or the patients in which we want to give less of fluid, like fluid restricted patients, and in patients of shock to gain some time, in pancreatitis patients, peritonitis patients, and in cases of post-operative albumin loss. These are the indications for using colloids. Especially the human blood, this produces a more lasting expansion of intravenous fluid volume than crystalloid, and that's why it is preferable if we want to increase the oncotic pressure and if we want to maintain the plasma volume as compared to the crystalloid, and crystalloid rapidly enters the interstitial tissue. So for maintaining any volume, any fluid inside the plasma, colloids are very important. Examples. One of the example of colloid is xylofusin. Xylofusin means succinylated gelatin or degraded gelatin. It's a bovine collagen. The T half of this xylofusin is around 2 hours in plasma, but it is associated with increased bleeding time in post-operative phase. If we are giving this xylofusin in post-operative patients, it may be associated with increased bleeding time. Another colloid that is available apart from this hemoalbumin, blood and blood components, the dextran. It's a glucose polymer mixture. Plasma half-life again 2 hours, and the major side effect of this dextran could be it may be associated with anaphylactic reactions and profound coagulopathy, maybe DIC sometimes. Another example of colloid is hydroxyethyl starch, and this HES, but it is having variable plasma half-life and it has unpredictable or variable effects on plasma expansion, plasma volume expansion. The next one is albumin, human albumin. It's a plasma protein and it is sterilized by ultrafiltration process. Here the important thing is this 5% albumin is isotonic with the plasma, whereas 20% albumin is hypertonic. But this albumin is rarely used as volume expander. Only few indications are there. But yes, if patient is suffering from hypoalbuminemia, this 5% albumin can be used, and sometimes 20% albumin can also be used if patient is having less of albumin due to some liver disease or some other causes. And finally, the blood, platelets, fresh frozen plasma, cryoprecipitate, all these things they come under colloid, and details we will discuss in some blood transfusion or other lectures. So for the time being, after this going through the colloid part, take home message is the best colloid that is available for human beings are blood and blood components. In cases of emergency, till the blood is not available, we can use the other hydroxyethyl starch or crystalloid, and if the albumin is low, albumin is a serum albumin is an investigation in case of liver function test, and if albumin is low, we can always give human albumin to restore it. There is a condition, there are some special circumstances where some fluids are indicated, and what are those fluids? We are having hypertonic saline with a concentration of 1.8%, 3% and 5%, and at the same time we are having hypotonic saline that is 0.45%. These type of crystalloid, they causes significant fluid shifts in and out of the cells. So they can also cause cellular injury especially to neurons, our central nervous system. So these type of fluids should be used very cautiously. No rapid infusion should be given, right? So in cases of hyponatremia, this 3% saline in India is very commonly used. Outside India, 1.8% is also available. And in cases of diabetic ketoacidosis, this hypotonic 0.45% saline is frequently used. Any patient, if any patient if presenting with disorientation, altered sensorium, and if we have suspecting a significant disorder of sodium balance, right? And if that patient requires a non-isotonic fluid supplementation like hypertonic saline, we must admit that patient in intensive care unit or HTO. Please remember this. So, all the patients of severe hyponatremia or hypernatremia and hyperkalemia or hypokalemia and even hypercalcemia and hypocalcemia, less of calcium, more of calcium. All these type of patients, they should be advised admission and then manage. So that is all for this video. We'll continue in the next last video of this fluid optimization, third video. Till then, bye bye. Thank you.